Welcome to this podcast from the Medical Journal of Australia. My name is Sally Block, the MJA's news and online editor. This podcast is made possible by Macquarie University Hospital, part of MQ Health. Lung cancer isn't Australia's most common cancer, but it's the deadliest. However, early detection and new treatments are changing this tragic statistic for the better. Today we're going to be hearing about robotic technology and AI and their role in the treatment of the disease in the future. To tell us more, I'm joined by Professor Michael Wilson, a leading cardiothoracic surgeon at Macquarie University Hospital. How does a multi-disciplinary team improve lung cancer care, and what is the GP's role within this team?
So the standard referral for treatment for lung cancer is usually through a GP, either having a symptomatic lung cancer or something incidentally discovered because they've had a test for some other reason, such as a calcium score for coronary artery disease. And then they're referred through a variety of specialists, including respiratory physicians, and then depending on the stage of disease, surgery, oncology, or radiotherapy. And the staging and assessment of the best possible treatment is where the multidisciplinary team really excels, because you have, looking at each individual case, a variety of specialists with each of their areas of expertise. And there's been an explosion in oncology therapies. So, years ago it was one therapy, if anything. And now you've got both chemotherapy and immunotherapy. There's a variety of genetic gene rearrangements, which then can be identified with gene testing, and then specific therapies directed based on that if they've got more extensive disease, or if you're trying to downgrade the extent of disease to make the surgery more possible. So the landscape has vastly changed in the last decade.
Can you elaborate more on this?
So before, if you had lung cancer, 95% of people presented too late to be treated as they had advanced stage disease, and there is really only radiotherapy and fairly old-fashioned chemotherapy. And now you have gene panel testing, PET scan staging, so that we're able to get the best possible preoperative or pre-treatment assessment of their staging, and various biopsies, either with ultrasound, CT scan guidance, or transbronchial biopsies with either endoscopic guidance or CT cone beam guidance. So we're able to diagnose smaller and more peripheral lesions earlier and provide appropriate treatment before the cancer is spread, so that cancer is far more treatable now than it ever was.
How do you incorporate advancements in imaging and diagnostic tools into your surgical planning for lung cancer patients?
The 3D mapping of arteries, veins in the lungs and bronchi, and the relative tumour positions allows us to start planning to do less invasive and preserve normal lung tissue and just take out the most relevant area. And if somebody's got reduced lung function from smoking damage, emphysema or something like that, it may mean that they can be operated on, whereas they wouldn't tolerate a standard full lobe resection of the lung. And the other thing, intuitively, if you've got an early cancer, it doesn't make sense to take out a whole lobe for a sub-centimetre nodule that's either cancerous or precancerous in its growth. So being able to map the extent of disease and the appropriate size of resection with a keyhole or robotic or minimally invasive approach. And there are other therapies such as lesional radiotherapy or excision biopsies. So the armamentarium has really vastly expanded in treating lung cancer.
How do you create the best outcomes for lung cancer patients?
It's a team approach in diagnosing and getting the lung cancer early enough to be treated before it's spread outside the lung, and then designing or planning the most appropriate resection for the size of the lesion, and taking the draining lymph nodes so you get the most accurate pathological staging of disease, so that the between 5 and 10% of patients will actually have occult or undetectable lymph nodes by any other means other than histopathology. So it's only when you actually take the lymph nodes out and look at them under a microscope, you can see the cancer cells have started to metastasize to the lymph nodes. And that upstages them. So they then need systemic treatment as well as a local cancer resection So the principles of surgery is to completely resect the cancer and do comprehensive node dissection to then stage the cancer and work out what the most appropriate treatment is. We're getting better at the genetics, better at the morphologic assessment of the cancer, whether it's spreading through the airways or to the lymph nodes, blood vessels or lymphatics.
What innovations do you find the most promising in cardiothoracic surgery?
Well, robotics really, for the last decade or two, there's only really been one robot that's been available, and that's the Da Vinci intuitive robot. In the last couple of years, there's been an explosion of development out of China, India, and to a lesser extent the US with further robots, so that there is now up to 50 different robots at the International Robotics Meeting available to do a variety of different things, whether they're catheter-based robots, single-site entry robots, the use of video-assisted surgery versus robotics. When it comes down to a more complex resection of the segmental architecture, so taking small bronchi, arteries and veins to remove the critical segment of the lung and leave as much normal lung as possible, the robotics really does have an advantage in terms of the instrumentation and anatomy. And you can have a simultaneous vision of the imaging to compare with what you're actually seeing in front of you on the robot panel using their Tile Pro features. So as it'll continue to evolve, but the sophistication of being able to take a lung out through minimally invasive technology with small 1 centimetre ports, unfortunately, you still have to make one of the incisions big enough to get the actual lung specimen out. But if you can avoid spreading the ribs and causing extra bony pain like that, it's then a much faster and better recovery to return to normal function. So robotics has a big role to play, particularly in that area where we're getting the early detection of lung cancer with lung cancer screening so that we can remove cancerous or precancerous lesions when they're tiny and peripheral, and use a variety of technologies such as also fluorocyanin, a fluorescence way of imaging where either injecting into the lesion, the bronchus, or perfusing the normal lung around the area so that you can demarcate the segment of lung to take that has the lesion in it and get a comprehensive staging with lymph node dissection through a minimally invasive approach.
How often would there be a discrepancy between your expertise and AI?
I've got a particular interest in that, and we've developed a platform to store and manage the imaging of the surgical footage and the team management. AI is just going to keep evolving, and the biggest risk is that you then get either what they call mirages or false positives, where they start to say a procedure is good when it's in fact inferior to what an expert would do. And so you want the really good surgeons being at the forefront of training the AI and ratifying it and make sure it's actually able to identify the anatomic structures and proceed with the operation in a chaptered or staged fashion so that you can then move through it and assess how each part of the operation has been performed and develop a scoring system from that. If you look at the driverless cars, they're flawed and they're still issues, but eventually they'll work them out. And the same is also true for surgery. So if you can have an augmented reality where you're sitting in a console, you see some aberrant anatomy, it can be identified by the computer vision AI model that's working with you, and it can look up on the vast data bank it's got and say, well, these are the 3 solutions which work with this anatomic variation. And you can have that sort of a virtual image projected in front of you. So you've got a assistance in what you then need to do in a surgical variation if required. And again, the peer-to-peer communications, what would you do here? All of those things are going to mean that instead of surgery being a one-to-one sort of trainee cadetship, you've got a many-to-one experience to benefit the individual patient.
Could AI pick up things that surgeons can't?
The AI is not really to the point there where we can start testing it yet, but that's coming. And you only have to look at ChatGPT. We've got simulations where we can actually record what all members of the team say, do speech to text transcription, and look for appropriate interactions, closed loop communication, so that when you need to do something quickly and efficiently, it's all carried out well. So the AI is a good augment, yet it's not really at a point with computer vision and surgery yet where it's able to compete or really identify things. But what we need to do as a profession is have our own imaging stored in such a fashion that we can make sure that the AI is appropriately taught and managed, so that we do get the patient benefit from augmented realities, cross realities. And I'm sure eventually at some stage in the future there'll be some kind of independence, but that's a long way off yet.
Could AI pick up things that surgeons can't?
The ability of a computer program to process multiple lines of information at once will always be superior to a human who tends to be line of sight focused, and you can see one thing at a time. So if you've got both a X-ray, an echo, a hemodynamic profile coming through, as a single operator, you tend to be focused on one thing. And what you see at the end of the instrument, there may be an off-instrument injury, there may be other issues happening. So it has the capacity to process vast amounts of information simultaneously and give better overall assessments. So as surgeons, our role is to make sure what it's identifying at each step of the way is the best and most accurate, so that it gets appropriately trained. And imaging is vastly different from the internet and the large language models that ChatGPT and the others are using. So it has to be good imaging that's appropriately analysed and annotated, so that the AI, as it gains knowledge of anatomy and procedures, develops appropriately. And it's in its infancy now.
So the checks and balances need to be meticulous.
Developed and maintained by experts who then make sure that the direction in which the AI is heading is appropriate and that it continues to learn and develop. Now, it has a massive capacity to do that, but if it goes down an erroneous pathway, so it's valuing time over surgical precision and outcome, then it will give false results.
So it's much more refined than, say, ChatGPT?
Yeah, see, the written text is everywhere, but vision isn't. And quality vision with high resolution that has been assessed so that the AI can be trained on it, that's a long way off what the World Wide Web and Internet offer for ChatGPT.
What does better screening do for patients?
That it continues to evolve, so we detect and treat lung cancers earlier and earlier. We're getting better genetics in terms of who's at risk. We've got better screening. Lung cancer screening is just in its initiation phase across New South Wales at the moment, and that will vastly increase the number of nodules, some of which will not be cancer and won't be appropriate to remove, but some will be early cancer detections. And if we can treat these at a time before they spread, then the outcomes from lung cancer will be vastly superior than they have been. And Kings of England have been operated on when they're inoperable, and our imaging is now vastly superior to that, so that the rate of inoperable situation where somebody has a cancer operation started and then terminated because it's not possible has vastly decreased. So it will be a better staging, better operative strategy on smaller and smaller lesions at a time when we can get a more complete resection and better cure.
What is your vision for the future of lung cancer treatment and care?
I think lung cancer, because it's been around for such a long time, isn't as sexy as breast cancer or prostate cancer, but it's one of the most prevalent cancers. And, it's 10% of all cancers. If you look at the incidence of cancer in somebody over 70, 10 out of 50 people will have cancer, and at least 10 of those will have lung cancer. And if we can detect this earlier so that they're not dying of their metastatic disease, and only 5% of the people with lung cancer are treatable, if we can turn those numbers around, we've then got an approach that vastly impacts on the population and improves outcomes.
How will early detection impact on the prognosis for lung cancer patients?
At the moment, it's the incidental lesions which have the best outcomes because they're picked up at an early stage. And that's not screening specifically for lung cancer. That's because they've had a CT calcium score because they're worried about coronary artery disease, or they've had back pain or chest pain or abdominal pain for some other reason, and it's been found as part of their workup for something else.
So these treatments are changing the future.
with this sort of exponential expansion of different modalities, that's why an MDT is so important. So you can actually manage things. And it's like melanoma, things that were inoperable before are now treatable with multimodal therapies, with chemoimmunotherapies, radiotherapy and surgery.
My special guest has been Professor Michael Wilson from Macquarie University Hospital, part of MQ Health. You can find more podcasts on our website at mja.com.au or wherever you get your podcasts. Thanks so much for listening.